Can you see my video tak? Tak keluar Kenapa? Something is not. Wait, let me try and share screen. Can you see my screen? Yeah. This one, nampak tak?
Yes,
Nampak, Doktor.
Dr. Syed.
But you can see me. So my camera is not working. That's fine. But you can see the slide lah.
Yes, Dr. Syed.
Okay, all right. So, inshallah we won't be long. Usually it's gonna take around 1 hour for both lectures. It's okay. It's all right. The first thing is about is basically just briefing for you all. So first thing is I would like on behalf of the pediatric department, I would like to welcome all of you to pediatrics posting. So you all are year 5 kan? So you've done pediatrics in year 3 and that was before the COVID pandemic. So I think you should have got a better experience in pediatric before. What is happening? Okay. All right. So I hope you guys had better experience with pediatrics before. Now we are in the COVID pandemic, so things are getting more complicated. But I think as most of UIA punya staffs are already vaccinated, at least SASMAC staffs are vaccinated already. We'll be getting our second dose probably in 2 weeks' time or so. So I think things will get better for you all as well. Hopefully, and then hopefully you all will get vaccinated soon as well, and hopefully we'll win over this COVID-19 sooner rather than later, inshallah. Okay, so there's a lot of restriction, things like you cannot come in. I think you should have got some briefing about SASMAC before. Have you got it? Briefing about SASMAC, but it's around the same as previous posting. So maximum in one group is 6. You cannot go to the ward more than 6, but you can do 6 students in one cubicle. So there's limited number of students. That is why sessions like this, ideally it should be done face to face, but the problem is we cannot have, I don't have time to go to COM, so it can only be done in SASMAC. The problem is when it's done in SASMAC, you cannot come, all of you, 27 of you cannot come to SASMAC at the same time. So that's a problem. So hopefully things will get better, but I think that's it. Okay, all right. So pediatrics posting. So this is another posting where if you look at adults, for example, if you handle internal medicine. So internal medicine is a posting that yeah, it's interesting, lots of thinking and so on and so forth. But you know, adults, they are at the end stage of their life already. But in pediatrics, children, they are at the very beginning. They have huge potential. So what we are working for the future. We are treating the future of Malaysia. Can you imagine? I've had my patient before, who I looked after from the patient was just 7, 8 years old, and then I continued to look after the patient until she was more than 20 years old. So can you imagine? And there's one story which I like to tell as well. I had one patient who I saw when I was in Houseman. At that time, I was in orthopedics department. So no, I was in surgery. This lady came in with abdominal pain, so they referred to surgery, and then we sort of think that, oh, probably the problem is actually the patient is probably pregnant. So then we referred to ONG, and yeah, the mother was pregnant in early trimester, had some probably ovarian cyst or something. So we referred to OAG. So and then after a few postings, oh, sorry, sir. Hello. Okay, all right. After a few postings, then I went to ONG department, and again I saw the mother as well. I think the mother was admitted for some reason. I don't actually remember what's the reason. And then after ONG, I went to pediatrics. As HO, we changed after a few months. We changed department. So when I was in pediatrics, that time I think was the year 2006, 2007. So and then there was major floods in the whole Malaysia, especially Pahang. If you remember, even I don't know how old you are, 2007. So masa tu, you know, there's a bridge along the Jalan Muazzam, Kuantan Muazzam, Segamat. There's a bridge there that connects from Gambang to Muazzam. So there's a bridge there. That bridge fell down because of major flood. So at that time, I was in HDAA, and what happened was we received a call. There's a baby coming in from Muazzam, will be flown in by helicopter because you cannot go. Muazzam is like is flooded. The whole area is flooded already. So there's no way they can bring the child over to HDA. Not even lorry, not even anything. Can only by helicopter. So they're transferring a baby by helicopter. And I was the HO in charge of on call overnight. I received the baby, and lo and behold, that was the same baby, which I saw when the mother was pregnant and I was in surgery, whom I saw the mother when I was in ONG, and now I'm receiving the baby when I was in pediatrics. And I did the exchange transfusion overnight because of severe jaundice. And then after a few days, and then we discharge the patient, and then I come back. I did a few more posting. Then I come back to pediatric as MO. I saw the patient again because the patient developed Bartter syndrome. So I saw the patient. And then after I finished MO in HTA, I went to Muazzam. So I did 1 year plus as MO in district MO in Hospital Muazzam. Again, the patient was from Muazzam. So I saw the patient almost once every few months. And I accompanied the patient from Muazzam to HTA several times. And then after Muazzam, I went back to HTA. Still, I saw the patient. And then I went for my master, did my specialty training. Then I come back to HTA as specialist. Still, I'm seeing the patient. So this is the type of that's why I'm saying pediatrics is interesting. So this is the only posting where you are encouraged to play with your patient. You need to play with your patient. You cannot play with your patient in internal medicine. You cannot play with your patient in other departments. But in pediatrics, you need to play with your patients. You need to kick ball with your patient. So this is very interesting. So you should enjoy pediatrics. The only problem now is because of MCO, children are not going out, so they are not sick. We don't have that many patients. We don't have that many patients with dengue. We don't have that many patients with pneumonia because children, they are not exposed. But now they're going to school. From last week, they are going to school, so we are expecting more pediatric admission. Last week, primary 1 and 2 and 3. Today, even until the whole primary school is going to school. So we are expecting more and more children getting sick. So that is why previously even having exam is a bit difficult because we don't have that many patients in the ward because children are not sick because of the MCO. Okay, all right. So there'll be 8 weeks for year 5. So 7 weeks and then 1 week of exam. Okay, so your group will be 7 weeks of face-to-face teaching. And then your working days and hours are Monday to Friday, 8 to 5 p.m. It should fall within the academic calendar. We require to have 100% attendance on all clinical rotation and teachings. If you are not absent, you need to obtain permission of absence from the lecturer or department office, Sister Farah. Okay, and then if you don't attend regularly, then we can bar you from going for exam. And then attendance record will be recorded through Google Form and should be filled for each class. Failure to do so will be taken as absent for the whole class. Clinical rotation, this is in ideal setting, but HTA hasn't allowed yet for us to go to HTAA. I think HTA only allow students from WIDAT going there. So this is a problem, but hopefully in the next few weeks, probably you can go to HTA as well. So probably more exposure in HTA. Okay, all right. And then, okay, so students are required to confirm the classes and clinical teaching with the respective lecturer or specialist, ideally a week prior. So the thing is, there's so many timetable, there's so many things. So you do need, and then again, when the department created the timetable, it's quite impossible for Sister Farah and team to actually arrange the lectures according to our clinical rotation, according to our clinics. Because like me, my clinic, Dr. Mossak has clinic on Monday, Dr. Taufik has clinic on Tuesday, Datuk Fadil has clinic on Thursday. My clinic is on Wednesday generally, but I do have extra clinic on Monday and also on Thursday or on Friday. So I have more clinic than others. So sometimes we need to reschedule teaching session according to clinics. And also this whole month, I'll be covering NICU. So if there's any emergency, then we do need to postpone classes. Like last week, I have two lectures with year 3 that I need to postpone to this week, which I don't know when, because of emergency cases in NICU. So you do need to confirm with your lecturer what the time that we can do. Sometimes we do need to delay to after office hour or over the weekend, but inshallah we'll make sure that you will have the adequate teachings to make you competent in pediatrics. So confirm with your lecturer, and then we do have several modalities. Ideally it's face to face, but again, face to face, the whole of you we cannot do in SASMAC. So that's the problem. So if we want to do with everyone, we need to do it in COM. We cannot do in SASMAC. So that's a problem, especially when we have clinic, especially when I'm covering NICU. I don't like to go far away from NICU. So I do need to be somewhere that they can call me and I can rush within 5 to 10 minutes if there's any emergency. So that's the problem. So we do have several modalities. We have Zoom, like we are using now. We have Google Meet. We have Microsoft Teams. Ministry of Higher Education actually paid for us to use Microsoft Teams. We have Cisco WebEx as well if you want to use. But generally, most of us prefer to use Zoom, because I think Zoom is more user friendly. I think it's better for this type of teachings. And for Zoom account, one thing I need to remind you, this Zoom account, these are not university paid account. These are personally paid accounts. So we have two accounts. This account is my personal paid. I paid myself using my own money. This is the link that you are using. And the other account is Dr. Taufik punya account. So also these are all not university yang bayar. These are all we pay ourselves because we feel that we need to use Zoom better than Google Meet or Microsoft Teams. So please respect that amount of money that we pay to use for the, because if you don't pay, you can only, the class can only be for 45 minutes. So that's why we think we do need to pay. So please respect the usage of this. So don't use these Zoom links for chit chatting and so on and so forth. And ideally, like if the teaching starts at 10, don't come in earlier. So probably you come in like 5 minutes before, because we do record all Zoom teaching online in the cloud. And we don't have extra money to pay for the extra cloud space. So there's a limited cloud space. So join in maximum earliest is 5 minutes before. Don't join in early, because everything will be recorded. Then it's going to be, this one I used to stay, because all the recordings will upload in YouTube. We have a pediatric department YouTube page, YouTube accounts, which you can access. All the lectures previously is there in YouTube. The problem is it takes time actually for us to review, and sometimes we edit. So if you chit chat, you ngumpat apa-apa semua, if we don't edit, it will come up in YouTube as well. So it won't reflect good on you. So, but sometimes we don't have time, so we just copy and paste. But it does take time for us to actually edit. I used to stay up to 1 to 2 a.m. every day to edit the videos and upload. So it takes a lot of time, and I'm already exhausted. So I passed most of the job to Sister Farah, but I don't think she can do it every day as well. So please respect the space that we are using. So join in the earliest 5 minutes before the scheduled time with your specialist. And because as I said, we have two links, so you do need to confirm with, even though it's my account and Dr. Taufik's account, the coordination for which link will be by Sister Farah. So Sister Farah will tell you which link we're going to use, because if one lecturer already used this one link, so probably the other lecturer, even me, I need to use Google Meet, Teams, or other or other links, on so on and so forth. So this will be organized by Sister Farah. So confirm with Sister Farah what time we are going to do the class, get the link, and please give the links to your specialist. I personally, this morning I didn't ask your group leader this morning because, well, I was busy doing rounds in NICU. But so you do need to give the links earlier to your specialist, because most of the time, if you don't give the links early to your specialist, the specialist will assume that you don't care. So when you don't care, we also don't care. So give the link to your lecturers early so that we can get the teachings early on. So join the teachings at earliest is 5 minutes early. Don't join too early. Don't join late. And then don't ideally don't chit chat in the rooms, and so on and so forth. And please don't these links you can actually activate, you can, because we, like this one, you can start at any time. So please don't use this link at other time other than the one that we plan. The thing is, because this same link will be used for many other reasons as well, for many other classes, for many other teachings, for many other meetings. So only use on your teaching time with the slot that is given to you by Sister Farah. Okay, all right. So throughout the posting, students are required to submit one case write-up and or case summaries, and total of 10 clinical cases should be clocked on the last day for the week 7 for year 5. So the case write-up, case summary, you need to submit to your supervisor, to your mentor, at least one. Okay, that will contribute to your total marks of the posting. And then we have an exam. All right, total 10 clinical cases clocked. If we don't have many patients in the ward, then we understand lah. So seminar, clinical, background presentation, so average marks is over 10. And then seminar attendance and also presentation marks that we'll give. Some lecturers like me, I prefer to give directly the marks to Sister Farah. So what you do is, you like me, you tell me your name, which presentation that you give, and then I'll give the marks straight away to Sister Farah. Some other lecturer would prefer to give to you directly with the comments and so on and so forth. And then procedure presentation. So we have some procedures that you do need to present. So ideally, it's actually you observe the procedures, but because we don't have time, so we have to do the procedure presentation. So you decide. So with the supervisor, some of the procedure that you should discuss and present. So guidelines of clinical teaching and posting at SUSMEC, at IUM and HTAA. So grouping shall consist maximum of 6 students per group. So we divide into 3 subgroups into A and B. This one, Sister Farah will just reconfirm with Sister Farah. So each clinical group is allowed to be in the ward for bedside teaching session for 1 session per day, with a maximum duration of 2 hours per session. The one that's presenting can come in the ward 1 hour earlier to clerk the patient. And only one clinical group is allowed to be in particular or clinic at any one time. and schedule for student rotation at suspect any stage shall be prepared by respective department. And then attire, student must wear proper attire with name tag. So you in the hospital, you do need to wear your scrubs. So you cannot go and wear whatever you want to wear your scrubs. So, okay, all right. And then you change back to you shouldn't wear scrubs straight to your hostels. So you need to change back to your normal clothing. So student must wear appropriate level of PPE during teaching or clinical session. So like generally you need to wear level 1 PPE, which is plastic apron, mask, all the time wear mask and face shield and gloves when you touch patient. So students are allowed to be present at the following areas: ward, clinic, labor room, this one, and also NICU. So we should have some of you going to NICU as well and following rounds. So rounds in NICU usually start generally around 8:15, 8:30. Students are not allowed to go to other wards, so you cannot go to medical ward and other wards and so on and so forth. So why do you need to expose yourself to risk? We don't know who has COVID, so don't expose yourself. Reduce your exposure. Students are not allowed to be present in the following areas: SARI ward, COVID ward, transit ward, emergency department. So except for green zone, others you are not allowed to be there. Okay, so you can do what round, what work on call, and you can be there. Seminar rooms, there's a maximum capacity, mostly is around 15, so that's why we cannot do our teachings there. Okay, and then these are the SOP. So all classes should be hybrid mode, so some element of online and some element of face-to-face. And then always wear face mask, wash hand, and so on and so forth. Observe the SOP, social distancing. Okay, students are required to follow CPRC. And then this one, so students from red zone areas, you are required to be aware of the announcement. And then when you're allowed to be back on campus, symptomatic students are not allowed to return to campus. And then these are the same thing. Okay, all right. Clear? Any question? Oh, it's already 25 minutes. This is not good. Okay.
Dr. Syed,
Yes.
I'm Shamel. I would like to ask, do we need to do a ward procedure? Because there is a part for the ward procedure in the logbook. However, during internal medicine, we are not allowed to do the
So
procedure.
I think it's the same. There's few reasons. The first thing is we don't have many patients, so that's a problem. So how can you do procedures when we don't have patients? Sometimes we don't have any patients. Sometimes we only have one patient. Maximum we have 4 patients. So we cannot do procedures. But that's why what we did is we do procedure presentation. So you have sessions with your lecturer where you present certain procedures. So lecturer will decide which procedure that they want you to present. So then you divide among you lah. So with me, I have list of like 8 or 10 procedures. So you divide among you who present which procedure, and you present and discuss. Okay, boleh, Aci?
Okay, thank you, Dr. Syed. My
So,
second question,
yep.
um, may I know about the format of clinical examination? Do we still use modified long case for this block?
The answer is we don't know. The answer is we don't know because the thing is, one thing is modified long case is not good because modified long case is so difficult to fail. It's extremely super easy to pass. So it's not good because it doesn't assess you properly. We prefer to have the usual long case, short case setting. So ideally, it's long case and short case, but most likely because of the pandemic, then we do need to do this still modified long case. When we'll know, we'll only know a few weeks before your exam. Before that, we don't know because we need to have meeting with the academic department, academic office, and so on and so forth. Okay, alright. Modified long case ni kacang ke kan? Okay, alright. So we don't have much time. We'll go through. Sorry, yeah, let me make sure because I have patients in clinic which I need to see. Okay, all right. So the topic, correct kan? Prematurity and its complication. So this won't be long, even though ada 67 slides, but we won't go through everything. Okay, so prematurity and its complication. So definition. So which baby that we determine, we define as premature. So preterm or premature, can you see my slides? Okay, so premature infants are
Yes, Dr. Syed.
infants or babies born before 37 completed weeks of gestation. So from 0 until 36 plus 6. So before 37 weeks, they are considered as premature babies. So there's a new definition, new pun dah almost 10 years lah, which is a late preterm infant. So late preterm are babies born between 34 and 36 weeks gestation. Moderately preterm infant are 32 to 36 weeks, and very preterm infant are less than 32 weeks. And then the other thing is the birth weight. So LBWs are babies born less than 2.5 kilos. VLBWs are less than 1.5 kilos. And ELBWs are babies born less than 1 kilo at birth. So because all these things, they are associated, the more premature the baby, they are associated with more complication. The more smaller the baby, they are associated with more complication. Higher risk of NEC, higher risk of hypoglycemia, higher risk of chronic lung disease, bronchopulmonary dysplasia, higher risk of so many other complications. So in the US, less than 1 kilo accounts for 99% of babies born less than 1 kilos are premature. And then 1 to 2.5 kilos, 7 point account for 7.2%, and 60% of them are premature. More than 2.5 kilos account for 92% of babies, and 7.6% of them are premature. So there's overlap between prematurity and birth defect. So and low birth weight as well. Obviously, premature babies have low birth weight, and babies with congenital anomalies, they also either usually they are born premature, or they also have they have low birth weight. They are microsomic as well. Okay, and then these are the number. We are not going to go through all this. So leading cause of infant mortality in the United States, so mainly is birth defects followed by prematurity, syndrome of sudden infant death syndromes, and RDS. Oh, sorry, because I'm covering clinic as well. Okay, sorry. There's a case they need to discuss with me. Okay, all right. So prematurity is associated with lots of is significant number of infant mortality. And then okay, all right. We do not need to go by that. So and being born premature is associated with significant economic consequences. For example, before I came back, I did my subspecialty training in London, in UK. So for every baby that is admitted in NICU, the NHS, so in UK they have this NHS. NHS is actually free. So everyone that got treatment from NHS is free. They don't need to pay anything. But the government by NHS pays the hospital. Sebab dia tak ada proper hospital, dia tak ada government hospital. The hospital does not belong to the government. The hospital belongs to trust, foundation, to trust. So, and the NHS pays the hospital. The hospital decide dia nak bayar doktor ni berapa banyak ke, they decide themselves. But NHS pays the hospital. For example, if a baby is admitted in NICU, the charge is around £1,500 per day. £1,500 per day. That is NICU. HDU around 800 to £1,000 per day. SCN around 300 to £500 per day. Transitional care is around 80 to £150 per day. So that is expensive. Even in Susmek, initially, our charges account for almost 1,000 per day for NICU level of care. So now me and Dato' Fadil, we are revising the charges because 1,000 ringgit per day is exorbitant. Even if you go to private hospital, for babies, they are admitted in SCN, special care nursery, not HDU level of care, not NICU, but SCN in private hospital. Per day, the charge for the baby is almost 1,500 ringgit per day in private hospital for SCN level of care. So this is expensive, especially if you're paying by out of pocket. If you have certain insurance, there's not many insurance covers babies. Newborn babies, not many insurance covers. Prudential have one package. The mother pays an extra insurance and it covers the baby for 3 months. But even that, Prudential only covers for the baby if NICU is 150 per day and SCN 70 ringgit per day. Other than that, the patient still need to fork out their own money. So it's expensive. It's expensive. I give you other example. If we send, so even if you go to Kementerian Kesihatan, if you go to KKM, yes, admission is almost free. It's 1 ringgit per day, 1 ringgit. Admission 4 ringgit, 1 ringgit per day. That's considered cheap lah. But sometimes, you remember newborn babies, if they have problem, sometimes I've had experience where we keep the baby in NICU for 1 year, 1.5 year. We keep the baby in NICU for 1.5 years. In Susmek now, we have one baby who has been in our NICU for 7 months already. So if one day is 1 ringgit in KKM, so 1 year is already berapa? 300 lebih dah, just for admission. Susmek, we charge each baby, just being in NICU is 150 per day. So now this baby is already here for 7 months. Ni just being in NICU, saya tak kira lagi charges lain semua. So it's a lot of money. Kan? If you do blood, for example, if you put PICC long line, the charge is around 1,000 ringgit. If you do blood culture usually is around 100 to 150. Blood culture, urine culture, 100 to 150 per test. If you do full blood count, it's around 30 ringgit. So it costs a lot of money. Even if the patient is not paying themselves, that money comes from someone. It either comes from the government or it comes from the insurance, but it must come from someone. If it comes from the insurance policy prices will increase. People yang nak beli insurance kena bayar more sebab kena bayar mahal. If it comes from the government don't have money, government will increase tax. So it always comes from someone. So being born premature, it's a huge consequence to economic effect. So average length of stay, so usually uncomplicated newborn probably 2 days stay. But prematurity average is 14 days stay in the unit. But if there's any other problem, chronic lung disease, average length of stay is 24 days, which is long. As I said, I have baby here in our unit, 7 months already, another baby already 3 weeks, 2 babies already 3 weeks. and one baby, another two baby already 1 week plus. So they are long stayer in the ward. It really is a lot of money. Not just the parents need to pay for hospital charges. Parents need to pay. If mother stays in our ward, mak rooming in, mak kena bayar RM50 satu hari. Kan? And then cost of travel. We have parents coming from Muazzam, coming from Rompin, coming from Kemaman, Parker. Kalau they travel every day, twice per day, how much money is that? So it's a lot of money. It's a lot of money. So we're not going to go there. So I've told you basically it costs a lot of money. It costs a lot of money. And then if the child is problematic, sometimes the child has severe jaundice. Sometimes the child has prematurity associated with lots of neurological sequelae, bronchopulmonary dysplasia, needing oxygen, balik rumah pun pakai oxygen. These are all costs. If the baby has neurological sequelae, kan, cerebral palsy, and so on and so forth. These are added costs for educational, added costs for social and community services. All these are more costs incurred. Physiotherapy, kan, diet at community level. So all these are added costs. So public opinion, so many women think baby born premature is meant to be and is preterm birth cannot be prevented, but premature birth actually can be prevented. So this is one thing. And then prematurity is associated with genetic. There can be genetic. So if your siblings that are born premature, it's a higher chance for you to be born premature as well. There's environmental influences. What are the condition of the mother, and so on and so forth. So prematurity is the #1 cause of neonatal mortality in the United States, and it is the #2 cause of infant. Infant is less than 1 year old in the US. Okay, we are not going to go there. So what are the problems with being born premature? So at the neonatal period, you can have respiratory distress syndrome or hyaline membrane disease where there is surfactant insufficiency. You don't have that many surfactants. So surfactant maintains the surface tension and keeps the alveoli open. So RDS, sometimes the baby needs to be ventilated, and we need to give surfactant. Surfactant mahal. One surfactant is RM1,000, one vial. So and then they are at risk of intraventricular hemorrhage, bleeding in the brain. So bleeding in the brain can cause lots of complication as well. There can be increased intracranial pressure, anemia. The blood then may clot and it blocks the what's the Allah, I don't remember. So it blocks the pathway from the through the third ventricle. So it causes hydrocephalus, for example. PVL, periventricular leukomalacia, is associated with long-term neurological sequelae. They are at risk for necrotizing enterocolitis, where the bowel become dusky, infected, it can rupture, and babies need operation. Necrotizing enterocolitis is associated with 30% risk of mortality. And then patent ductus arteriosus, because the smooth muscle is not strong enough, so they have patent ductus arteriosus with heart failure. They are more at risk of infection because their immune system is low. They have lots of metabolic and abnormalities such as rickets and so on and so forth, and nutritional deficiency. So short-term issues is feeding and growth difficulties, because for example, less than 34 weeks, before 34 weeks, these babies, they cannot suck and swallow. They don't know how to suck. So sucking, swallowing are reflexes, primitive reflexes. But before 34 weeks, they cannot suck, they cannot swallow. So these babies, they can only be fed by rice soup. So they may have lots of feeding and growth difficulties as well. They are prone of infection because they are admitted. They have poor immune system. Admission in NICU is a risk of infection as well. They have so many blood taking, venipunctures. All these are risk of infection. They are at risk of apnea or prematurity because their cardiorespiratory center is not mature enough. They are associated with neurodevelopmental difficulties initially, retinopathy or prematurity, and transient problem with dystonia, muscle tone. Long term, they are at risk of cerebral palsy. So prematurity is the main cause for cerebral palsy. They have problem with sensory deficit. Many of them, some of them need special healthcare need. They may have problem with incomplete catch-up growth. For example, our baby here, 7 months old, but growth is around 5 months old. So there's a problem. They have school difficulties. Prematurity is among the main risk factor for autism, for example, behavioral problems, chronic lung disease, so on and so forth. Okay, what are the conditions leading to premature birth? Yeah, either spontaneous or clinically indicated because of mother or fetus at risk, spontaneous cervical insufficiency, multiple gestation, pre-labor premature rupture of membrane, for example, and other conditions. So what are the clinical indications for preterm deliveries? Preeclampsia, fetal distress, IUGR, abruptio placenta, and when there's a fetal demise. So extreme ages of mothers has higher risk of premature delivery, low socioeconomic status, unmarried mother, and certain other races as well. Okay, we're not going to go there. So okay, over distension of the uterus, for example, is another cause for premature delivery. What are the common risk factor? Multiple gestation and prior this one, and also cervical length, cervical insufficiency, and so on so forth. Okay, let's skip that. Okay, let's keep that as well. We're not going to go there. We can assess this. ONG should tell you about this. We're not going to go there as well. Okay, so just know that there are uterine causes for premature delivery. Yeah, among them is like bicondylar uterus, cervical insufficiency, abruptio placenta, and so on and so forth. Fetal causes, fetal distress, multiple gestation, and so on and so forth. Polyhydramnios because of overdistension and mother goes into labor earlier, trauma, and so on and so forth. What are the acute problems? So these are the acute problems for babies. I've told you some of them to you before. Hypothermia. Why hypothermia? Because basically baby, do they have higher body surface area? Obviously adults have higher body surface area, but what they have is higher body surface area to weight ratio. So if you compare weight to weight, they have higher body surface area to weight ratio. So that is why they can lose heat more by radiation, by evaporation, and so on and so forth. So they have higher risk of hypothermia, and their thermoregulation center is not mature enough as well. So they cannot manage their thermoregulation well. They are at risk of hypoglycemia because they don't have much reserve. They don't have much reserve. To maintain temperature, they need the brown fat. Brown fat usually occurs, you have more brown fat when you are more than 36 weeks. Before that, you don't have that many brown fat. Brown fat is very important for thermoregulation. That's why they have hypothermia. Hypoglycemia, they don't have much reserve. They don't have much glycogen store in their liver. They are at risk of hypocalcemia as well. They may have respiratory problem with RDS and so on and so forth. Risk of IVH. Their liver is immature. That is why sometimes certain drugs they cannot produce well. They have higher risk of jaundice. They are at risk of infection because of the immaturity of the immune system. NEC, PDA, feeding issues, anemia of prematurity as well, and retinopathy of prematurity, and metabolic bone diseases of prematurity, and rickets of prematurity. Hypothermia, I mentioned before, because of higher body surface area to weight ratio. They have little subcutaneous fat because this, and then decreased brown fat. Brown fat is what controls is very good for heat production. Their sweating mechanism is not mature enough, and their thermoregulatory center is still immature. hypoglycemia because of lack of glycogen storage, and the autonomic response to actually uh, 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 properly control your insulin and glucagon. They are at risk of hypocalcemia because of immaturity of the hormonal control system. They are parathyroid hormone. They are still immature. That's why they don't process really well. Respiratory issue, high membrane disease, or RDS, RDS because of the surfactant punya deficiency. And then they may have apnea of prematurity. They just stop breathing. They just forget to breathing. Why do they do that? Because of the immaturity of the cardiorespiratory center. So that is why sometimes what we do previously, we used to give aminophylline, theophylline, but now we can give caffeine. So we can give caffeine. Okay, sorry. Can give caffeine. So IVH is common in preterm infants due to immature vasculature. The blood vessels in the brain are basically friable. The cerebral autoregulation of blood flow is not regulated well, so they are at risk of the burst from the blood. And then many of them have clotting problem, coagulopathy. That's why they may have IVH. Immature liver, so results in prolonged physiological jaundice. They are at higher risk of kernicterus and bilirubin encephalopathy. They are at risk of infection because of they don't have, because obviously maternal IgM do not cross placenta. Certain maternal IgM do cross because IgM is a bigger molecule. Dengue IgM, for example, crosses placenta. But generally IgM do not cross placenta, only IgG crosses placenta. And IgG only crosses the placenta in the last trimester, so around 28 weeks. Only they cross the placenta. Before that, babies will not get the maternal IgG from the mother. And then they also depend on IgA from the maternal breast milk. So if they are born premature, they don't have this protection that they're supposed to get from the mother. And the skin surfaces are more delicate, their mucous membrane are also more delicate, so they are more at risk of getting infection. And as well, because they are premature, we do IV cannulation. We poke the patient. We put endotracheal tube, nasogastric tube, all the lines and so on and so forth. All these are risk of infection. NEC, necrotizing enterocolitis, because of immaturity of the gut endothelial surfaces and enzyme deficiency, so they are at risk of getting all this infection. So the umbilicus may get infected and become necrosed, dilated, and so on and so forth. So that is why actually breastfeeding will reduce the risk of NEC. If you hear the last ICPC which I presented, we discussed about how breastfeeding, breast milk can actually help prevent NEC. Okay, and patent ductus arteriosus in premature babies, obviously it takes at least 5 days for it to close, and sometimes they remain open and so on so forth. Feeding issues because of uncoordinated sucking and swallowing, usually only around 34 weeks, the baby can start to proper suck and swallow. Sometimes they can suck, they can swallow, but there's incoordination. Anemia of prematurity because of lack of iron storage, vitamin E deficiency, and exaggerated physiological anemia. So they may have anemia of prematurity, and also because of blood taking. So if they are premature, we take blood. For example, if they are 1 kilo, the total blood volume in the whole body is only 80 mils per kilo. So the baby only have around 80 mils total blood volume. If we take blood, for example, if we take blood for coag, INR, PT, APTT, we need around 1.8 mils of blood. If we take FBC, we need around 0.5 mil. If we take RP, LFT, we need around 1 to 2 mils of blood. So can you imagine, if we take everything and blood culture, you need around 0.5 mils. So it's a lot of blood in a baby with only 80 mils total blood volume. So sometimes is basically iatrogenic. It's caused by our blood taking. Retinopathy of prematurity, the main cause for retinopathy of prematurity is being premature as well. So basically what happens is there's abnormal vascularization due to immaturity and oxygen therapy. If we give so oxygen, you need to remember oxygen is a drug. Oxygen has complication. And among the complication of oxygen is retinopathy of prematurity. So that is why if you give more oxygen, extra oxygen that the baby doesn't need, you may cause the baby to be blind because of retinopathy of prematurity. Rickets of prematurity basically because of lack of substrate, calcium and phosphate and also vitamin D deficiency results in rickets of prematurity. What we can see is low calcium, low phosphate and also the alkaline phosphatase will be elevated more than 600. And then long-term problems such as chronic lung disease or bronchopulmonary dysplasia. This is one of the complications because of oxygen. If you give more oxygen, the baby may need long-term oxygen therapy. Poor growth. Why? Because the baby is emitted for a long time. There's not much stimulation and so on and so forth. CNS dysfunction, again, because of stimulation. Can you imagine we have a baby here, 7 months old already, still in NICU, and the only sound that the patient hears every day is the machine punya sound. Machine punya sound. They don't hear people talking to them. They don't hear people reading to them. So how can they develop? This is a problem. Bronchopulmonary dysplasia, I can see here lots of cystic changes. What happens is the baby will need prolonged ventilation and oxygen. Prolonged oxygen. Because of why? Because of oxygen toxicity, because of barotrauma, volutrauma to the lungs, causing all this problem. Poor growth because of feeding issues, vitamin and micronutrient deficiency, iron, selenium, copper, all this can result in growth issue. And zinc deficiency may result in immunodeficiency as well. So because of micronutrient deficiency. CNS dysfunction, cerebral palsy, as I said before, prematurity is the main cause for cerebral palsy, IVH, and so on and so forth. And then post-hemorrhagic hydrocephalus, the child has IVH, blood clots, and this clot will then block in the I don't remember the name. What's the name? I don't remember. So basically from the ventricles to the third ventricle, it may block and cause hydrocephalus. So this is what we call as post-hemorrhagic hydrocephalus. Prematurity is associated with learning problems such as autism, dyslexia, risk of deafness because of the premature, and also because of high jaundice, because of gentamicin, certain drugs that are ototoxic. And then mental subnormality as well because of hypoglycemia, because of high jaundice, because of so many things. It may cause problem with the IQ. So these are the problems. So there's a lot of problem associated with prematurity. So the most important bit, the most important part is actually identifying which mothers are at risk, which babies are at risk to be born as premature. So we need to plan. Being born premature, again, the risk is there, but we do have babies. I've had patients who were born premature, but now are studying in Oxford, for example. So they can do well, but they do need proper care. What they do in many developed countries, they do now is specialized hospital. So in Malaysia, for example, even premature babies are handled in all big hospitals. But like in developed countries, what they do is certain region, there's only specific hospital handling specific problem. For example, deformity hernia is only handled by King's College Hospital. Babies with cardiac problem, they're handled by Evelina Children's Hospital. So sometimes they're specialized center of care. Extremely premature baby handled by this hospital. So the staffs are more expert and so on. But in Malaysia, we cannot afford that. In Malaysia, we cannot afford that because we don't have that many facility. We don't have that many pediatrician. We don't have that many in Malaysia. We only have 4 pediatrician now in Susmet. We only have the whole country. We have less than 20 neonatologists. URA we have 2, me and Dr. Mossad. HTA have 1. Hoshas do not have any neonatologists. Many hospitals in Malaysia functioning without neonatologists. We don't have that many neonatologists. So that's a problem. We cannot provide adequate level of care without adequate number of sub specialty. Okay, all right. Boleh? Any question? Clear? Faham? Tidur belaka?
Dr. Syed, I have a question.
Yes.
Is there any specific reason why unmarried mother is also a risk factor
No, there's no
for
reason.
prematurity?
We don't know. It's just an associated findings that we saw, is not just in Malaysia but throughout the world as well. Probably it's just because of how they are looking after themselves. It's just an association. We don't know the actual reason. Same like low socioeconomic status. Why? We don't actually know. It's just a observation. It is associated with low socioeconomic status, associated with certain races. Okay, anything else? Clear? Faham? Boleh buat? Prematurity masuk exam yang last group baru ni. I think block 2, year 5 block 2 punya PMP, the question is about RDS. Prematurity and RDS. So it can come out in exam. Obviously, prematurity will not come out in clinical exam, but it will definitely come out in theory exam. Okay, boleh sekolah 1 hour, exactly 1 hour. Okay lah, alright, fine. If there's no other question, you can ask me later during next teaching session. I presume, I don't even know when I have other teachings with you. So your representative need to contact me again. I haven't got the chance to actually look at what are the next lecture I have with you as well. But contact me again. And I don't remember. Did we already have session with the whole of your batch ke? With me ada tak? Tak ada lagi. Ke dah ada?
For prime, is it?
Prime ada.
Nephrotic syndrome. Yes, we had a nephrotic syndrome before.
Okay. Alright. Just tak apalah, nanti remind me if I have time, at least with your batch lah, with your group ni. We'll do some if we have time, we can do some extra teaching such as how to approach a certain physical examination, how to approach developmental assessment, how to approach neurological assessment, how to approach cardiovascular examination, understanding the pathophysiology behind certain physical findings, respi, cardio, and so on and so forth. So that we can do ideally face to face, but we can even do as online. Okay, all right. Remind me, inshallah, we'll have that session later. Okay, let's end our session with Hasbika Farah and Suratul Asr. Okay, Assalamualaikum.